education as the highest education, but there are other regions that have no formal education at all. And as social workers, when you go to their communities, they should inform how we educate or how we communicate to the community members, because their understanding may be different. So when you're communicating to them, you have to put into perspective the education level. Decision-making power within household greatly influences healthcare access. Women who have a say in household matters are more likely to seek timely medical care. But however, many communities that we visited, men still hold a primary decision-making authority. And we believe that this limits women's ability to independently access healthcare. And when we go along through the findings, you will realize that most men do not even want women to make independent decisions regarding their healthcare, their reproductive rights, and all those stuff. So we assess the household health, leadership in the household. And after our analysis indicates and still confirmed that men lead the household, maybe due to cultural norms and the dynamics and other stuff. But we still have about 6.8 women who lead the household. These studies use only couples. So if we found 6.8% of the women leading the household, then we still have to delve deeper to see why now we have some women leading in the house or as the head of the house. Decision-making power. Who has the decision-making power among them in the family or in the household? And if you check very well, 82% of the decisions that are made in the household relies on men. Women do not have the chance to make a lot of input in decisions when it comes to decision making. Everything relies on men. If you look at the regional breakdown, check the northern region, check the Uti region. Those regions, women do not have a say when it comes to decision making in the household. So there are notable variations in gender roles and decision-making power. And some regions exhibit more egalitarian decision-making, while others still adhere to patriarchal norms that limit women's influence over health-related matters. So if we check, the blue colors indicate men's power, whilst the light green at the tail end indicates women's power. And you can just agree with me that women may not have a say when it comes to deciding on their health. So we wanted to know, when it comes to major decision making, who is in charge, or whether they both is equal to men and women. And on this note too, in many cases, women are socialized to refer to men. And I think that's what happens in our community, that men is superior. So in any decision, it should be the man. And that was what our studies find. About 59.68% said decision making should be solely the decision of the man, not the woman. So as I said earlier, we wanted to know, because women should have independent decision, have the ability to make independent decisions. And our study found that about more than 70% of them indicated that women should not allow to have any autonomy to make decisions on matters. And I think this is a cause to worry, because women may have reproductive health issues. There are certain things that women find it difficult to disclose with their spouses. So if they are still not able to make decisions on their own, then it is challenging, and something that we need to look at on this day. Now let's clearly look at the table. We assessed few indicators here. We're looking at economic activity. We're looking at economic resources, use of household income, what to cook. When you look at all these things, aside with the exception of what to cook, which women can decide at mostly, almost, or even bed spacing, use of contraceptives, how when to visit the clinic. They were all the prerogative of under prerogative of the man. Is a man that may have to decide whether women should have access to all these things. And you visit some families, NHIS card is with the husband. And I was thinking like, so if men are supposed to, or if men are keeping the NHIS card, what happens if a child is sick and the man is not at home? So then what contributes to power differences among what contributes to the power difference among the GMFs? So the slide I've just shown highlights how societal norms shape power differences within household. Women's economic contribution office go unrecognized, reinforcing men-dominated decisions. So it's not about what the women contribute. They are looking at cultural norms, which is leading across the 7 regions that we went, that contribution of power in the household basically is based on the cultural norms within the locality, age, income, religion, but the most important thing mentioned was cultural norms. And when you look critically at the regional distribution, you can say that northern region, OT region still repeats here that cultural norms indicate the source of power in the household, whereby we have few regions indicating income and age. But northern region, OT region, western north region is basically on cultural norms that give the power or that gives power in the household. So as an organization or civil society interested in women's health, we asked few questions, and the key ones that came out was sexual and reproductive health issues. Women told us during the study that they find it very difficult to discuss sexual and reproductive health issues with their partners. And it is so alarming. Imagine a woman wants to go in for contraceptive, and that woman cannot discuss with their partner. A woman is having sexually transmitted infection. And if you have worked at the hospital before, you see that most of them will come with sexually transmitted infection. You ask them whether their partners are aware, and they'll tell you that they are not able to discuss this with their partner. And all these things affect the health of women, the health-seeking behavior of women. So on our key findings, we found that 82% of respondents identify men as their primary decision makers, and cultural norms, economic factors, social factors, and religious beliefs contribute to power imbalances affecting women's autonomy in healthcare choices. So when we went to women's participation in community leadership and healthcare, the study also found that most women are not part of the community leaderships in the communities we visited. And this is also an issue because women have unique needs, and these needs need to be heard so that in planning up or designing our policies, these things will be factored. But if men are to decide for women, then men will always be lacking when it comes to accessing quality healthcare. So we also find out that on the health-seeking behavior of women, our findings indicated that 24.4% of respondents had not visited a facility in the past year. Barriers such as high cost, lack of essential medicine, and distance contributed to this trend. So people are not visiting the facility because of these factors that they mentioned. NHIS enrollment too is higher among women. Most of the women have the NHIS card, but also it's not active, maybe due to their economic power, because they may not have money to renew it, and they find it difficult to discuss this with their spouses. They don't have the NHIS card. 34% of respondents were aware of NHIS subsidized services, but they still opted for pharmacies or self-medication due to perceived inefficiencies in our public health care facilities, which we have to advocate for efficient and effective public healthcare facilities, because if these facilities are available in the communities, we expect that that should be the first point of care, not the pharmacy or other places. This may also inform our education and also our advocacy, because we need men, no matter what, we may need men to do most of the things. So we ask them whether men support them when it comes to assessing facility. Men were doing well in antenatal, postnatal, delivery. Most of them with joined their husband, maybe due to the seriousness and the severity of it and the emergency it comes with. When it comes to family planning, birth spacing and limiting, most men don't seem to be interested in those areas. So there's a need for us maybe to do further studies to ask them why they are not interested for their spouses to go into for contraceptives. So now our recommendations. We want to inform partners that there's a need for us to strengthen women's leadership and participation in primary healthcare decision through targeted empowerment programs, leadership training, and policy reforms. So we have to be involved. We have policies person on a panelist, so that you have to bring us on board so that we assist in the reforms of policies. And I think ARHR was part of the current policy reform that was made under the gender ministry. Improve access to affordable healthcare by addressing NHIS enrollment gaps. I think a key thing that we also now NHIS is seeking to tell us that primary healthcare at the CHIPS zone is level, but it's free, but there's a need for us to probe further to find out whether that may not prevent people from renewing their insurance. If they go there and they refer them to the health centers, what happens? Are they not going to pay? So it's something that we should still have to look at. Enhance community education through localized outreach programs to raise awareness about primary healthcare services, NHIS benefits, and the importance of timely medical interventions. And with this, we have already started with our gender model families community education, whereby we are educating women about their health rights, services that the primary healthcare facilities provide, and the need for them to engage and be part of the leadership in health. Lastly, we also seek that they should establish more inclusive and responsive feedback and accountability system to ensure service improvement with a focus on gender-sensitive approaches that amplify women's voice in healthcare governance. It will also be good to integrate gender transformative approaches into national health policies to create an enabling environment for equitable healthcare access and decision-making at all levels. There's a need for us to foster partnership between government, civil society organizations, and local community to drive sustainable improvements in primary healthcare service delivery. So on that note, a special thank you to my executive director for this opportunity to lead the team to do the presentation. We also want to thank Dr. Ofe Abuaje for leading us and coaching us through all this. And we want to thank everyone for joining and for joining this discussion this morning. Thank you, and over.
Thank you very much, Benjamin. Well done. You've done it in record time. I was pushing you to keep the time, but you've done admirably. Well done. Ladies and gentlemen, he's talked to us about the barriers of PHC to women and girls, Women's Leadership and Agency. He made reference to the nuances, the difference in the findings based on regional feedback, the contextual issues and how they influence decision making, what women can discuss with their partners and what they can't, health-seeking behaviors, and the women's assessment of men's support, especially seeking family planning was something that they did not do, or maybe third of the women realized that they didn't enjoy their husband, or they weren't able to actually men support there. Again,